Hereby I open this academic ceremony at Maastricht University. My name is Ton de Goey. I am the prorector of the ceremony and chair of the degree committee. First of all, I welcome Mrs. Anna Dania, and she will defend in public her academic thesis, which is entitled Perspectives on the Development and Sustainability of Practice-Based Research Networks Worldwide. Welcome all members of the degree committee present here and present online. And I would like to introduce the 4 supervisors to you. This is, first of all, Professor Jean Muris. He is Professor of General Practice at Maastricht University. Professor Solt Narikaldi, he is present online. He is Professor of Family and Preventive Medicine at the University of Oklahoma Health Sciences Center in the United States. The third supervisor is Professor Chris van Weel. He is Professor of Family Medicine and past president of WONCA, and he is affiliated with Radboud University in Nijmegen. And the fourth supervisor is Dr. Ari Haranen. He is a university lecturer in health pedagogy at the University of Eastern Finland in Kuopio, in Finland. I will introduce the 5 opponents later during the ceremony, and I welcome all followers of the live stream. Mrs. Dania, may I invite you to give a summary of your thesis? The floor is yours, and I wish you success in the coming hour. The floor is yours.
Thank you. Dear Prorector, dear members of the opposition, dear supervisors, dear colleagues and friends online, I will briefly explain my dissertation titled Perspectives on the Development and Sustainability of Practice-Based Research Networks Worldwide. And I will start first with an explanation how practice-based research emerged. It emerged from James Mackenzie in the 19th century, a Scottish doctor, and then continued by William Pickles and John Fry in England into the 20th century now, Curtis Hames in the US, and Frans Hygien in the Netherlands. All of them documented their observations on the medical problems of their patients and studied disease patterns. Frans Hygien also organized the earliest practice-based research network in the Netherlands in Nijmegen in 1967 that continues today as FAMINET. Let's see why the family doctors take this on. Because they play a central role in their patient care. They are the first point of contact. They develop connections with their patients and communities they serve. They see every kind of health problem, often unfiltered, and they see their patients holistically. And then they are in a unique position to observe how health and illness develop and how services work. And they know what truly matters to their patients. And they need real-world data and evidence to improve their care. Let's see what are practice-based research networks. They are long-term collaborations of practitioners in the field with the clinicians, with academic researchers, with the purpose to investigate problems emerging in the daily patient care using real-world data and generate knowledge which ultimately improves the primary care. They are the research laboratories of primary care. Over the last 50 years, many of these networks have been developed around the world. Their strength is that they can quickly collect and analyze real-world data from the communities they serve, and they can identify and do research on emerging health problems and inequities. And also they are capable to test treatments and care models in the settings where most of people receive their care. Many of these networks have been inseparable part of the healthcare systems in some countries, but in some other countries or cases, They have been struggling, but their long-term sustainability determines if this real-world knowledge will continue improve primary care and feed the knowledge of family medicine. This is what this dissertation studied. What helps practice-based research networks develop successfully, what barriers they face, how leaders manage to sustain them, and what lessons emerged from the global experience and can be shared internationally. I will speak about the research methods. Because we wanted the most of the information to have a complete picture, we looked at every source available in the international literature across all the history of the practice-based research networks in English language, and we gathered a large volume of information which we organized in 2 scoping reviews. One explored the internal environment of building 93 networks from 15 countries using 229 sources, and the second explored the external environment of building 98 networks from 16 countries using 260 sources. The reviews identified facilitators and barriers and also key elements of practice-based research network development and sustainability. However, we realized that documents alone cannot explain leadership decisions and real-world experiences, and we decided to implement the consultation exercise of the scoping review methodology, and we interviewed 56 network leaders from networks of different maturity, organizational style, and stakeholder engagement and infrastructure. And finally, because this research had the roots in Finland, where the first, let's say, literature review happened and motivated us to investigate further the global experience in building PBRNs, we tested the global findings if they were applied nationally and in a context where the practice-based research networks were in infancy. We surveyed the chief physicians, who are the key decision makers for the primary healthcare centers in Finland, and we used the questionnaire based on our scoping review findings. And here is what we found. Practice-based research networks evolve hand in hand with family medicine and primary care. They do well where primary care is valued, and they strengthen it in return. The national context is very important for their success. A strong research culture in family medicine fuels networks. Education that waves research into every practitioner's training nurtures networks. Patient registration and gatekeeping systems support very much the development of practice-based research. Also, our studies consistently showed that there was a universal developmental pattern across the 5 decades of global experience with practice-based research networks, and the networks often learned from each other, and they followed remarkably similar development paths, although they were happening in different historical moments. But the similarity in their steps was not just an imitation. It was reflecting the natural path to maturity. Let's see what was the strongest facilitator. It was relationships. Networks evolved successfully around collaborative, reciprocal, synergetic, respectful, and trusted relationships between academics and practitioners in the fields. In addition, we confirmed that the academics are very much motivated because research generates scholarly outputs valuable for the scientific base of the discipline. And practitioners are motivated by improving patient care. They are also strongly committed, if research goes hand in hand with training that upgrades their skills, active knowledge sharing, is rooted in real practice problems, and provides tangible benefits such as professional credits, academic appointments, compensation for the time spent in research. This was also confirmed by our findings in Finland. The chief physicians were motivated to participate in research when research addressed real-world problems, when it improved their own practice, and when it would provide clear reciprocal benefits despite the competing priorities. So, with different methods and in different contexts, we had the same conclusions. Here is what else we found. Practice-based research networks are not static organizations, they are adaptive systems. Over time, they engaged more stakeholders, such as patients, community groups, trainee doctors and residents, academic institutions, other healthcare stakeholders, and expanded the reciprocal and trusted relationships with them. And they succeeded in aligning with the broader community and healthcare context. And that enabled shared research agenda setting, shared research implementation, shared research translation, and this stakeholders' stable commitment. As a result, the networks evolved into collaborative research and learning ecosystems where knowledge sharing and co-creation were common practice. And this was part of their learning environment, which was a fundamental element of networks. Their flexible and inclusive framework and the multidirectional communication supported learning communities that enabled collaborative research translation, best practices implementation, and innovation sharing. And this resulted in practice improvement, better patient outcomes, and policy impact. And that boosted their sustainability. Lately, the embedding learning health systems in their operations has been a new practice for strengthening the learning environment. Let's see what was the biggest challenge. It was infrastructural funding and institutional backing, which were essential for their sustainability. When these were awakening, networks had to respond either with organizational transformations, which included purpose-driven partnerships, networks of networks, and also merging into larger networks, or they had to redefine their agendas and develop a diversified research portfolio and business models also. Or they had to implement both pathways. Last, I will speak about the key finding that had the greatest impact from this dissertation. Many leaders that we interviewed stressed that the national support is not enough, and there is need for global advocacy for the value of practice-based research networks, need for mentoring, and also multinational, cross-regional research collaborations and methodologies to enable them. These insights led to the creation of the Global Practice-Based Research Network within the World Organization of Family Doctors. The initiative began with 45 doctors from our study and grown up to 270 researchers and network leaders. And it gets strong support recently also from the North American Primary Care Research Group. The initiative supports global research collaboration, shared learning across the global community of networks, mentoring for building new networks, and advocacy, as the findings of this dissertation suggested. In conclusion, primary care research networks around the world share common developmental experiences. This means that they can learn from each other and grow together. The core principles identified in this dissertation provide a foundation for building and sustaining networks across different countries and contexts. From this foundation emerged a number of implications, practical implications, for startup networks, practical guidance for building new networks, for existing networks, recommendations to strengthen their long-term sustainability, for primary healthcare practice, improving care quality through the integration of networks into routine clinical practice, for education and training, strengthen clinician research skills and involving them in practice-based research, for professional organizations, strengthen the national advocacy and collaborate with the global practice-based research network initiative, and for future research, studies exploring factors influencing the network's development in settings where this activity remains underdeveloped. Closing, I would like to say that this dissertation developed a vision for a practice-based research network for every community around the world, which is part of the advocacy through the World Organization of Family Doctors and the North American Primary Care Research Group today. Thank you. I would like to acknowledge that the contributors to this research and the committee that made it possible for me to stand here today. Thank you very much.
Thank you very much, Mrs. Dania, for a clear summary of your thesis. The opposition will be opened by Professor Jochen Kals. He is Professor of Family Medicine at Maastricht University. Professor Kals, the floor is yours.
Thank you. Dear candidate, first of all, many congratulations on completion of this wonderful thesis. I think it's been an interesting and long journey across the world. And it's a thank you for asking me to assess it as well, because I've learned a lot from it, especially in the light of the development of academic living labs nowadays in the Netherlands, which are somewhat bigger than the practice-based research networks. So it's very interesting to read your work. And also congratulations to your supervising team and a very international team, but also including a team member who's actually the successor of Professor Huygen, who actually was the founder of the first practice-based research network in the Netherlands, which is wonderful. I think your work is an encyclopedia for everybody who wants to set up a practice-based research network. Now, also turning to your cover, Alice in Wonderland, I think Alice finds herself in her adventures navigating in a world which is fragmented, different characters, different rules, different spaces, yet gradually more or less finding some coherence in that. Now, I'd like to discuss especially chapter 2 and 3 with you, and because you present 2 scoping reviews. Mm-hmm. And can you explain the rationale for structuring those in 2 different chapters and not combining them in one?
Well, the volume of information was so large that actually I had it in mind yesterday evening. It was about 13,000 words, and I showed it to Jan, and he said that this is impossible. And we were trying to find a method to present these findings on a way that it would be, let's say, rational. Mm-hmm. And if you go to organizational science, you will find out that the terms internal and external environment exist in the organizational science for businesses and organizations. So it is fully applicable that we can define external and internal environment, which reflect also the macro and micro perspective of an organization. Mm-hmm. And of course, we had the stakeholders at the intersection, which was a phenomenon that we revealed during our study.
Yeah. And now if you then look back, because I agree there's lots and lots of information in these two reviews, and it would have been probably impossible to combine it in one.
Yeah.
Yet, if you reflect on conceptually on the internal and external factors you determine in these chapters, to what extent do you feel that they're somewhat artificial or more maybe conceptually combined? Because there are factors which overlap in the internal and external factors. Do you agree?
I think that, for example, if you consider the health information technology that exists in every office, doctor's office, and also exists in the external environment, yes. But we saw the stakeholders with a view, the actors, from the perspective of how they are standing in comparison to the organization of a network. Are they standing in the core of a network? Where are the academic practitioners and now the patient, the community groups intersect, and sometimes policymakers or other healthcare stakeholders, like, for example, the Healthcare Trust, intersect? Or they were positioned clearly outside. They were outsiders who were influencing. Mm-hmm. This was the definition, and I think it is very, very much aligned, as I said, with the organizational science.
Yeah. But then if I go onwards and read your qualitative work, but also maybe the Finnish case, but mostly the qualitative work, you describe some dynamics and also some themes where factors such as leadership, culture, stakeholder engagement, and funding, they appear highly interdependent and also reinforcing each other. But these themes or these factors are all both internal and external factors, right?
I think that these factors you are mentioning were internal, more internal. They can be, for example, external stakeholders like policymakers who may intersect today and don't intersect tomorrow. Mm-hmm. But then this specific moment when they intersect, they act like internals. They participate, for example, in advisory groups.
Mm-hmm. But in other instances, they would act as external factors as well.
Yes.
Yeah.
That's why they stand at the intersection.
Yeah. And now, if we look at the current situation in the Netherlands, there's the development of academic living labs, which is our larger practice-based research networks, where also the GP cooperatives play a role, and those are the organizations combining the different GP practices in the area. Mm-hmm. If you reflect on your findings in your thesis, what would you advise us how to incorporate these cooperatives in the light of new academic living labs?
I think the cooperatives can have a very strong role. First of all, to reflect on what is needed in primary care, and also give an insight of what the practitioners need to involve, what is meaningful for them to engage. And I would think that they can be internal or external stakeholders. Occasionally, they can be, for example, members of a network, but also as a group, as a total group, all the practitioners of the Netherlands, an external group for some other network. But still, I think they should intersect and somehow provide information about the practitioners' growth and engagement. Mm-hmm. Because the engagement problem is a little bit complicated nowadays.
So these cooperatives can be both internal and external. So
as I said, regarding their network, they belong to internal, but if they act as a group, that are the group of practitioners, the Dutch practitioners in the field, then it is external.
So then we come back to Alice in Wonderland. Maybe there's different rooms and different boundaries.
Yes.
Thank you very much. I'll give the word back to the prorector.
Thank you, Professor Kals. The next opponent is Dr. Boutergiani. He is a clinical senior lecturer in general practice at Glasgow University and also the clinical lead for Scotland Primary Care Research Practice-Based Research Network. Dr. Jani, the floor is yours.
Thank you. Dear candidate, I would like to congratulate you for the work you've undertaken and the scale of the engagement you had across the world. My first question is related to the part 1 of your work on PBRNs. The literature search or the scoping review you conducted was from the timeline 1965 to 2020. And then the qualitative interviews you conducted, majority of this engagement came from PBRNs in North America, Europe, Australia, and New Zealand. So I would like to invite you to reflect on how the findings apply to PBRNs in resource poor countries and how what are the differences they may have to undertake if there's someone trying to establish a PBRN in the global south.
Oh, esteemed opponent, I would like to say that, yeah, that's a very nice question. I think that there is a general guideline and a general foundation from this dissertation, but we have to go into the national context and see, first of all, what is the position of family physician in the context? Because in many African countries, we see that the family physician is a very high standing position out of the community services that serve the daily practice. And then we have to consider how we will engage and how we will educate these people who stand in these positions in the community health service, for example, and how we can supervise them and connect them with research, and who will do the research. For example, I would recommend in these cases people who would be practice facilitators for such cases. And then I would see also problems like, because I am aware of that, problems such as some countries, they don't allow the practitioners to have access to their practice data, their electronic health records, and then they have to implement different methodologies to do primary care research, and they have to use different methods to gather their data. But I would see a lot of potential, first of all, learning from the more developed countries and the developed solutions, and I would like to see really publications from these countries. And I see also, and I know because I made already research in Africa, that there is remarkable obstacles in the regulatory environment which must be taken into account too. So I think that, yes, the national context is very important, and many factors, external and internal, that we already mentioned in our studies exist, but they must be studied in every national context.
Okay, thank you for that. My next question relates to the part 2 of your thesis and its relationship with part 1. So the part 2 of your thesis, where you did survey of chief physicians in different practices in Finland. The survey did not specifically ask about PBRNs or in particular about the barriers to research. It asked about what are the motivators, but it did not ask anything about the barriers to research participation or the prospect of establishing a PBRNs. So I wonder, how do you relate the part 2 with part 1?
You speak about the chief physicians in Finland?
Mm-hmm.
Thank you. Esteemed opponent, I would like to say that we did ask. We asked about a previous activity, research activity in the healthcare center, the last 18 months. And if they have an active activity right now or they plan in the future, and we asked if they would like to participate in a practice-based research network, explicitly.
And then did you explore the barriers of taking part in research in Finland?
Yes, they were thinking exactly the same like the scoping reviews, that they would like to have topics which will influence influence positively the improvement of primary care, and they would like to have topics that reflect the problems in primary care settings, and they were very much motivated in effectiveness studies. And I remember that they were also mentioning the effectiveness of digitalization, because it's a reality, very important reality in Finland, and very interesting development. And they were also thinking that research in their primary care center would raise the profile of the center and would give different value in the profile of journalist.
Okay, thanks for that. I would like to pass it back to the prorector.
Thank you.
Thank you, Dr. Jani. The opposition will be continued by Professor Bart Rutten. He is Professor of Psychiatry at Maastricht University. Professor Rutten.
Thank you, Mr. Prorector. Dear candidate, also from my side, compliments. This is a superb booklet. I've been reading it with great interest. As my colleague on the left-hand side, we're also trying to set up academic living labs in the Netherlands, and this is a really nice guideline for considering which steps to take and which steps not to take. And I think you have a wonderful piece of work here delivered, and it's also, I think, supported by an international promotional team with great expertise. I have a few questions, and one of this relates to, or the first one would relate to chapter 4, in which you consult people with great experience in setting up the PBRNs. And I was wondering, and you also, I think you discussed this briefly in the chapter, but also in the discussion, of course, if you invite the coordinators of the PBRNs to reflect on facilitators or barriers and so forth, you have quite a selection bias of people that you interview. Mm-hmm. And I was, so if you ask ambassadors, what do you like? Of course, they like what they're doing, and they would see it as being successful or effective. And I was wondering, have you been considering also inviting people that have a more critical perspective? And if so, which people have you, or which groups have you encountered during your long trajectory, and which you could have incorporated into the study? Because I think there may also be critiques, and it's a lot of time you have to invest in setting up the networks, you have to organize this and that, and what does it bring the person in the community? And that's sometimes, I think, evident, but not always. So I was wondering, how could you incorporate more critical reflections on the PBRNs?
Well, first of all, yes, we had. And actually, I didn't expect it. I mean, I was just trying to invite leaders who had different experiences. And suddenly emerged some leaders who had a very big disappointment with their network development. And I dare to say that this moment when we were reading the interviews pairs together, Chris von Wil said that she didn't do that, she didn't lead the network well. So I think that, yes, we had. And in one case, it put me really in difficult position because the network almost didn't work. So the person explained only the challenges and how they started, but they didn't evolve. In some other cases, which were just a handful, they told me about critical barriers that somehow did not let the network evolve further than what it has been, and according to my information, it remains the same situation. While the first evolved after our publications, and they have done very good work with business model development. And then there were networks that had some kind of startup with a hope that they will focus more in research, but they ended up to do more quality improvement work, which is also very welcome and very, very important. So I think that the leadership there was had a very important role, because I wrote, and we discussed it also in the Summit number 6 in the US a couple of years ago, that the modern management of networks needs to have kind of knowledge of how you will manage, how you will be a manager of an organization. Because when we want to have models, business models, and we want to have business plans and business thinking, we have to have a little bit more idea of what is business.
Yes, it needs different competences on leadership,
Yes.
also with managerial
Yes,
things.
yes.
So I was wondering if you would be able to choose one primary outcome measure that a PBRN is aimed to do. What would that be? That's one question. And would there be any ways of thinking about a kind of a mechanistic study on, because you have identified perceived facilitators and perceived barriers, but try to tease out what in actual real life works and doesn't work to achieve that ultimate outcome. Can you reflect on this?
See a study, a simultaneous study of better patient outcomes, together with effectiveness study.
What do you mean with effectiveness?
Cost effectiveness.
Oh, yeah, okay.
Cost effectiveness of networks integrated in the healthcare context.
Yeah, thank you very much. Do I have time for a last question? Which relates to Proposition 5. Could you read aloud, maybe Proposition 5?
Yeah, effective care is grounded in patients' experience and achieving the desired outcomes.
That relates a bit what you were just talking about. And I was also wondering, in your discussion chapter, I think, or it was the chapter before that, at least on page 163, you have a figure 2 on the learning environment of PBRNs, and you have the academic faculty and the primary care physicians centered.
Yeah.
What I missed there, and you put it as a kind of stakeholder, were the patients themselves. And I think you reflect on this in your discussion, saying, more recently, we always invite people with lived experience or patients to be a center member of such a built network. Mm-hmm. So how do you see this? Is this figure indeed that patients are one of the stakeholders, or would you rather envision them being more centralized?
I think.
And if so, how?
In the development of networks today, 2026, the patients can play a very important role, because exactly there has been a development of the healthcare in big trusts in many countries and big organizations and etc. So the role of the practitioner in the field as a, let's say, contributor in some cases has been awakened. So the patient role and the community role has been very strongly strengthened. But there is a trick there, because I was thinking about that not every time the same patients can participate in the same research, because their participation can be project-specific, or it can be really members of advisory boards in longer terms. And also, I would say that these people can make, they can receive training and they can have, as I said, very active roles. But still, I think, although care is for them, care is not for the doctors, it's not for anyone but for the patient and the community. But they are intersecting. They are not in, how can I say, in the core of the networks. They are intersecting, they are into that, but they are together also out of that, because they are the community, the social context, where all the healthcare and everything is standing.
Thank you for your response. With that, I would like to give the word back to the prorector. Thank you very much.
Thank you, Professor Rutte. The opposition will be continued by Professor Henk Schers. He's professor of general practice, in particular networked care in general practice at Radboud University, and he is also affiliated with the Department of Primary and Community Care at Radboud University Medical Center. Professor Schers, the floor is yours.
Thank you, Prorector. Dear candidate, first let me start to congratulate you on a beautiful PhD thesis. And let me also take the opportunity to pass my great congratulations to the supervising team. I think really great achievement, and must have been a massive amount of work reading through your chapters. And I was thinking that Frans Huygen, and Professor Kals already mentioned him, also would agree with my congratulations, because you may know that my practice, both clinical and academic, was built on the foundations of Frans Huygen's work. And so I fully agree also with the tribute you make in your thesis to all the founding fathers of PBRNNs. And yes, I have also some critical questions. And the first question would go to chapter 4, which is the consultation exercise. And there you ask the leaders about the sustainability of their networks. And when I read through the answers they gave to your question, there was a lot about, and that surprised me, was that they talked about infrastructural support, collaborative relationships, learning team environment, culture, agile management. But what they didn't talk about, as far as I could read, was about their mission. So I thought in the sustainability of the networks didn't play the mission of the networks any role. Could you reflect on that?
I am not sure, highly esteemed opponent, I'm not sure if I understand the question. I think that you mean that the sustainability of networks is related to the flexibility of evolving the mission and upgrade the mission over the years. Do I understand correct?
Yeah, what I mean is that when I think at least when you asked directors what would be important for the sustainability of the network, they talked a lot about process factors, I would call them. So is there, how's the environment, how's the management, how are the relationships? But they did not talk about the primary mission of their network. So does the mission of the network not play a part in being sustainable or not?
Yes, you are right. I didn't ask the mission of the network because we had a very big collection. This consultation exercise came to complement the scoping reviews. And we had a huge collection of purposes and missions of networks from the global literature. So I have been thinking that the issue of mission has been, let's say, reflected very fully. And we developed the interview guide thinking that we will cover answers or let's say let topics emerge that have not been covered by the global literature. The mission was really covered by the literature. Yes, we didn't do that.
Yeah, but in the conversations with the leader, that didn't become a major reason why networks appear to be sustainable, as I understand you well.
I think that the general mission of all networks is the patient care improvement. And I think being central to every network,
Yes.
I didn't see that there was any change over the 50 years. All the networks looked at the population health or the patient improvement. I think that was from the beginning till now. Some networks looked more, for example, at the population health. Some networks looked more at the patient improvement or care improvement but I think that the core mission everywhere was that.
Yeah, but I expected this answer. But as I read in your thesis, I thought that there was a tendency for networks to become bigger.
Yes.
And to become more responsive to population's needs, and also that more persons, people, organizations are involved in the governance of networks. So also patient representatives, politicians, financiers, etc. And when they are part of the governance, of course, they also determine what kind of research is being done. And I thought, reading this, is there also, do you also see a danger or a threat in this development where the mission of the network, as it was at the beginning of the network, may alter due to changes in governance and becoming bigger?
Highly esteemed opponent, I think that, as I said, the central mission of networks was always the patient care improvement. And thereafter, the involvement of various stakeholders may have changed foci or purposes. But this is normal because what happened before 50 years, let's see, for example, the weekly returns of Birmingham, they were developed to study the infectious diseases occurrence in England, in the English context. But now we are not focusing too much in the infectious diseases, except COVID-19. We are more focusing.
On the other hand, if I may interrupt you, if you look at the networks of the founding fathers, they are more the intrinsic needs of the researchers, GPs, starting them. And now all other, say, all people have different needs. And so being influenced by politicians or funding bodies is not always, maybe not always for the long term, the best. So there's a difference between research which is important now, which is directly important for practice, and which will be important in 10 years. So for this movement may be a threat to the last part, I think. Or do you look at it in a different way?
We have described that in the dissertation, yes. And I think that, yes, this can be a threat if you want to place it that way. But I think that if the mission remains, the central mission, the early mission, remains, let's say, as a compass for the networks, then there is no problem. And the practice has shown, the global experience has showed that they have not lost their steps making compromises for the funders or policy makers. Instead, I have seen that they have influenced policymakers, and bigger networks manage to influence more policies and guidelines, yes, and even play the role of positive for advocacy of the network's value.
Yeah. Okay, thank you. So it gives more hope than fear. And that would be a good end point, I guess, to be satisfied with your question, with your answers, sorry, and give the word back to the pro-rector.
Thank you, Professor Schers. The fifth and last opponent is Professor Joseph Lemaster. He is Professor of Family Medicine and Community Health at the University of Kansas Medical Center, and he is also Director of Practice and Engagement at Dartnet, in particular Family Medicine and Public Health. Professor Lemaster, the floor is yours.
Thank you, Pro-Rector. Dear esteemed candidate, I want also to congratulate you for this great amount of work that you have done. This is a long journey that you've been on, and all of us have great admiration for your work. I know that the findings of this dissertation and any publications that emerge from it will be of great interest to the PBRN community, at least in the US, where I'm from, but I think globally also. So I will go on to my questions. In chapter 3, you stated that you had chosen social network theory to organize and structure your analysis in your scoping review. Please identify the advantages and disadvantages of this choice as compared to organizational theory, which you stated could have been used, and why ultimately social network theory was chosen. You state that alternative theories were not in your scope, but this does not make clear the thought process behind your choice.
Highly esteemed opponent, thank you very much for your question. The inspiration for the social network theory application came actually from the classification that Frank Sullivan from Scotland provided me when I had interviewed him. There, in a publication of 2007, he describes that the UK networks had typically 4 types: the crystal type, carousel type, orbital type, and bicycle wheel type. And each of them had included different aspects of research governance. But if you see iconically, these 4, let's say, infrastructure building, you will see clearly that we are talking about nodes and ties. And the social network theory is based exactly on the concept of nodes and ties. So I thought that this is very ideal. And then I thought that I searched and I found that it has implications in healthcare. So I thought that, yes, it is the right way to go. Because the networks are really made of actors who develop nodes, and that the nodes are connected by the ties, which are the relationships. And then we have their contributions and attributes, which are the features of these relationships, and finally the outcomes, which are the properties they build. And these are very clearly defined in the social network theory. The other idea that was behind that was that because I have the background in economics, I was thinking that I would like to see the networks with a more social perspective and not, let's say, business-like. And the third was that if I would apply the organizational science, which I considered it, as I explained before, because when we speak about macro and micro and external, internal environment, and etc., it's organizational science. But yes, I thought that the concept of networks, practice-based research networks, was matching better with the social network theory.
Thank you. My next question, I will take us to chapter 5, the survey that you had conducted. You state in that chapter that you were unable to find a previously validated survey in this field, and so you had used one which had been created, it seems, by you for the use of this survey. For the use of this study. The reliability and validity of such a questionnaire will always be in doubt when this has not been established formally, which can also bring into question its results. Please, can you explain why you did not estimate, for example, test-retest reliability or internal consistency in your survey, and what you believe will be, therefore, the perhaps limitations in the publication of this or of its interpretation?
I would say that we simply did not consider it. We did not consider it when we decided to deploy it. We thought that also there was the survey was covering a lot of questions that has been used. They have been used in previous surveys for developing networks, and these surveys had been in the literature review of our scoping reviews. So I would say that the Finnish survey was important and meaningful because it included a considerable sample size for the Finnish standards. More than half of them answered. And I think that, of course, every study can have bias, but I think that the survey was a very good validation for our scoping reviews, but we didn't think the way you proposed.
Okay, thank you. Prorector, do I have time for another question?
Sure you have. Yes, please.
Okay. In chapter 4, in the chapter 4 results, you make the comment that professional organizations such as WONCA, NAPCRAG, etc., played an important role in linking and motivating academics and clinicians to initiate international, national, and local PBRN activity and facilitated the ICPC classification system. But you state in chapter 4 limitations that you cannot identify differences between urban or rural or higher or lower resource settings. Surely your observations about the role of organizations such as NAPCRAG and the breadth of your sample would allow some exploration of these differences, though in many countries, admittedly, PBRNs do not yet exist. Can you elaborate on why you focused on exploring the common ground rather than diving deeper into the differences?
Yes, because we conducted a scoping review, and the scoping review as methodology aims at developing a common ground. And this common ground allows further explorations where it is needed. And regarding this point, it came out of a reviewer's comment before the publication. But we had not opportunity to answer. We did not gather information if the network is rural or not. I mean, it could be possible that it emerges from the discussion because many of the interviewees had talked a lot without being questioned, and some interviews lasted very much. And we had gathered very interesting insights because of the freedom of expressing themselves. But we didn't have the opportunity to clarify, unless it was mentioned, if the network was rural or urban or whatever. It was not on the, it was again not in the focus of our questions.
Right. Thank you very much. Do you believe that there could be scope for such additional investigation in the future?
You mean, highly esteemed opponent, you mean in general from this dissertation or regarding the rural and urban networks?
Yes, the latter, please.
Yes, that could be possible, but I believe also that this is hard to...
Mrs. Dania, the time appointed to defend your thesis has passed. The committee will now withdraw to discuss the quality of your thesis and in particular the quality of your defense, and please await our return here.
Thank you very much.
Mrs. Dania, the committee here present has assessed the quality of your thesis and in particular the quality of your defense. And in view of a positive verdict, she has decided to grant you the degree of doctor. And Professor Muur is authorized to confer upon you this academic distinction in accordance with Dutch university custom and law. And I invite now your supervisors to take the floor. Professor Muur.
Please all rise.
First, I begin with I hope that you say, yes, I promise to this declaration of integrity. So do you, Anna Dania, promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent, and responsible?
Yes, I promised.
By the authority vested in us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Anna Dania, the degree of doctor and grant you all rights attached by custom and law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary, and the other members of the committee, and affixed with the official seal of the university. Now, this is the greatest part of this work. Not to disturb the seal. Congratulations. So smile. Cheese.
Thank you.
So you can put it.
Please be seated.
So Anna, it is not quite finished because many congratulations, and we are very proud, the supervisory team, that you did such a cool and awesome defense today. And well, you showed that you're really off on your topic of the core of your defense. And now in this year of 50 years of University Maastricht, that you defend the thesis on 50 years of PBRNs. That's a really magical Alice in Wonderland-like alignment. So I thank all the supervisors and colleagues also and friends online who looked at us. And now I will pass on for 6 minutes of laudatio to Professor Van Wil. You can stand here. There you go.
Dear Dr. Dania, dear Giovanna, it's a great privilege to bring you the laudatio of your thesis on behalf of, as well, Jean, Zolt, and Ari, as your supervisors. As I said, it's a unique thesis you've done. Usually in a thesis, a PhD track, there is a protocol first, usually done by the supervisors, and then a candidate is recruited. Not in your case. We got into contact, it's more than 10 years ago, I think it was, when you asked me very smart questions of the PBRN in Nijmegen. Who was it composed of? Who was in charge? Who was interested in where the money came from? Well, difficult question to ask. Who participated? And your questions apparently were part of a hypothesis, assumptions, and you started collecting data. I still remember that first conversation we had, particularly when you asked me the leading question if I was aware of other PBRNs in the world, because that enabled me to open the can of the research conference I had organized a couple of years earlier, and where we have collected PBRNs from around the world and saw that it was such a precious thing. You came back with more questions, and I saw a very fascinating pattern advancing. Who owned the PBRNs, who were the stakeholders, how do researchers and practitioners collaborate, or what factors in fact supported the long-term functioning and what impeded that, and what stood in the way. And gradually, and probably not previously thought through, an international collaboration evolved with many contacts with many PBRNs around the world. And then the fascinating thing, and that was so impressive, was that all these PBRNs who are embedded in the health system they operated in the culture and in the socio-economical conditions of the countries they worked in, they had a lot of common ground, and that built the idea of the platform, and that's why your thesis is such a wonderful thing. At a certain point, I discovered that your thesis, your study, was part of an idea of a PBRN, of a PhD. And so that was great work you had with Professor Mandisakula and with Haranen, and I thought that was so important because the work we do in primary care is so important to embed that into an academic situation. So what sad news it was a couple of years later when I learned from Zolt, when I met him, that there were problems with the progress of your PhD. That was dreadful. But what a delight it was when it was possible to bring you with the work here to Maastricht. And that it was possible to rescue the great work you with Arie and Zolt had done. And we were able to connect to that the great work of the Department of Jean and the work done here in Maastricht, and it enabled me to contribute what the work done in Nijmegen as well. So maybe for a moment I can deviate from the subject and thank the University of Maastricht for hosting this PhD. It's in line with the impressive history of this university that's done so much great for international primary care around the world. It's also a very personal thing. Today is really the very last PhD I've supervised. And I remember that when I started in Nijmegen in 1985, one of the very first things I did was contacting Maastricht to see if we could collaborate. We had a meeting with Professor Vert Steurmans and with Harry Krebel. That was the start. This is the closure. For me, the circle is round, and what a beautiful PhD to close that down. That about the PhD, that about the research, but there is also a person behind that PhD, or with that PhD. Giovanna, that's you. Now, looking back from the position we're in now, it all, with such a smart book, such a wonderful document, it all looks so great and easy going, but no PhD track is easy going alone. It all has its ups and downs, and you had your downs as much as the ups. I mentioned already the problem of the disconnection, the discontinuation of your PhD track. There were also moments when I think your health played up. And we didn't hear of it, but we occasionally picked it up because then your response to revision of papers was a bit slow. But before we really started worrying, you were back and you did all the great work again, and you continued working on it, and you brought a very complex database into wonderful papers. I was very impressed with the way you coped with the always critical editor of the Journal of the American Board of Family Medicine, one of the most prestigious journals in our field. You had huge data. You had made it into good, readable papers. And then, of course, you got the comments we always get: add more details. Oh yes, and skip 500 words. And you really did that. You solidly started doing that. A daunting task, and you had 2 beautiful papers that were the great start of the whole thing. But as a person, you remain a little bit of an enigma to all of us. A Greek living in Finland. And then I remember I always call you Giovanna. All the others call you Anna. So who are you really? I think we better now call you Dr. Giovanna, Dr. Anna Dania. Today is the very successful closure of your conclusion of your research and your PhD, but there is more. And I think already in your defense it became clear that there were other things you were doing. You're managing a network of all the PhDs you've studied. And you've been able to connect that to the 2 main international bodies of family medicine primary care, the World Organization of Family Doctors, WONCA, and the North American Primary Care Research Group, NAPCRAC. And all that is great work. Occasionally I was a bit worried that your working on that was taking over the completion of the PhD, but again you reassured me completely, and here we are today. So therefore it is that we are standing here as supervisors very, very proudly of you. So in conclusion, Giovanna, Anna, I take off my hat for you of the wonderful things you've done. On behalf of everyone, the applause is for you.
Esteemed Dr. Dania, dear Anna, I congratulate you, and it is a great pleasure to congratulate you with your doctorate. And I do that also on behalf of Maastricht University and the other 3 universities that are involved. I would like to share with you some impressions of the committee. And I would like to start with giving you a compliment about your summary of your thesis. That summary is meant for non-experts. And I think you gave a very clear survey of what you have done. And I think that universities, all of the universities are involved in this PhD thesis. It's good that these universities have now the opportunity, via your summary, to make clear to the general public what has been done by scientists, what they have done, how they have done it, and what the results are and what the impact is. So I congratulate you with the quality of your summary. With respect to your thesis, we have seen an extensive thesis of good quality and with very excellent and useful general reviews, scoping reviews of the field, of the literature. It's based on well-performed studies. It has also, the majority of the studies have been published, and probably some studies are still underway. And we are quite convinced that it will have impact in the field. With respect to your defense, well, you responded to quite a variety of different questions. And you responded to that in a confident way, explaining it honest and open. And the committee has enjoyed the discussion and are satisfied with the quality of your defense. I do not only congratulate you with that result, but also your 4 supervisors, Professor Jean Muris, Professor Zsolt Nagikaldi, Professor Chris van Weel, and Dr. Ari Haranen. Congratulations with the result that we have seen today. I would like to congratulate also members of your family and the co-workers that have worked with you during the last couple of years. I would like to thank all members of both committees, the assessment committee, but also this degree committee. Thank you very much for critically reading the manuscript. And Maastricht University and the other 3 universities appreciate your input. And I would like to give the opportunity to our online members to congratulate you. And I would like to start with Professor Zsolt Nagikaldi. Would you take the floor, please?
Thank you, dear Dr. Dania, Anna. What a wonderful occasion it is to say this. And reflecting back upon our journey, I actually found an email from 10 years ago. This was your first email, and I want to quote just one line because it has relevance to today's accomplishment that I fully and wholeheartedly congratulate you for. You said, currently I am conducting a narrative review for the key features of PBRNs in the last 2 decades, and I have included your network among the eligible networks. That was the first way you approached me, and that all immediately told me about your goal orientation. And as we started working together, I got to know you better and esteem truly your tenacity, the zeal that you have shown, and your determination to get this large project done. As others have stated before, a few times I thought that this might not happen, lots of other circumstances. But here we are today, and you not only pulled through, but you are building the future, in my opinion, of a global PBRN network initiative that is not the first of this kind, but certainly the most recent and some of the most promising. And so I also commend you for your inquisitiveness and your innovative thinking that I encountered several times over the years, and I couldn't be more happy today for you to see you there with your degree. I congratulate you and hope to continue our work together in the future. Thank you.
Thank you very much.
Thank you, Professor Nagikaldi. I would like to give the word to Dr. Botesiani.
Dear Anna, Dr. Dania, many congratulations for the accomplishment today. I've watched your work closely over the last 5 years, the work you've done in establishing a network of PBRNs internationally, and I look forward to working with you as part of that movement in the future. You deserve all the admiration you've received today, and hope you are able to celebrate your success fondly.
May I pass the word to Professor Henk Schers?
Yes, thank you. Yes, first, my apologies that I wasn't able to make it to Maastricht today, which was really a pity, but congratulations with a beautiful thesis, Anna, and a solid defense today. Great was it to be able to join it. It has been, as Chris stated, a long journey, but worth the journey, I guess, and ending or starting again with new things to happen. And I expect to see you around in the PBRN world in the coming years. And I hope that you enjoy the day, celebrate it, and see you in the future.
Thank you, Professor Schers. And I would like to pass the word to Professor Joseph Lemaster.
Thank you very much. Dr. Dania, thank you so much for the opportunity to be able to participate in this defense. This exhaustive study of exploring the full extent and characteristics of PBRNs globally will, I believe, be a seminal work that leads to extensive discussion, and we hope cascades of further studies by you and others on the topics that you've identified. I agree with the others who have spoken before me about the excellence of your defense and responses to our questions. You were cool, collected, and completely in mastery of your topic, as is appropriate for your award of this degree. We wish you all the best. We look forward to your continued leadership in this field and to the work that will come forward as a result. Our hearty congratulations.
Well, before I close this ceremony, I would like to thank again, in particular, not only all members, but in particular, the external members of the committee. Maastricht University appreciates your contributions, so thank you very, very much. Hereby, I close this academic ceremony. Stand together with us.